So welcome everyone to visit our Chang new development. So this is our Craniofacial Center and people from the research center also, including doctors at the front, orthodontics and research assistants all around. So big population of our center. So there's two parts of the center. One is for clinical service, and you can see in the center is the Professor Yuan Chen, and also our professors, Dr. Ke. She's the current head of the research center, and also senior Professor Luo. Professor Lo is the workhorse. He has the most publications in our center. I think maybe up to more than approaching 200, and still keep writing. And it's me. Why? This is Dr. Yi's event in March when she before her training or fellowship in our center. And this is last year. Changdong Forum combined with APCA, APCL, PC. Doctors are there. We had a good meeting. So this year also we will have Changdong Forum in this year, 2024. 28 to 30 October. Yeah, that's October. Don't worry. So if you want to keep on, please raise your cell phone and scan. Cedar body. Yeah. Or you can search Changdong Forum 2024. So we have many international speakers, also two from Thailand. And then here's the local speakers. And then our program is quite versatile. And then including the flap surgery, the orthodontic surgery, dental facial deformities, and OSA. And in the afternoon, we have many workshops, including orthodontics and surgical. The surgical workshop will provide the 3D simulation training using the computer program, and also have model surgery by 3D printing. This year, we prepare a case of very huge osteoma over the contact. Initially came for facial asymmetry and class 3 malfusion, but turned out that we find that it's an osteoma more than 3 centimeters in dimension. So it's quite risky and difficult. So let's come back to our talk today. Why you coming for as a plastic surgery training? Most of our plastic surgeon, we think about what is beauty. What is beauty? For male, do you know him? Probably not. I know. You know him, yes.
So usually we know him from his Japanese side. Actually, he's the half Japanese and half Taiwanese.
Yeah.
So Taiwanese people always know him from his Taiwanese side.
How many of you think he is handsome? Thank you. Okay, I picked the right one. So he's quite tall. He's 178, maybe shorter than you.
So he a little bit shorter, but more and more handsome.
Yeah. Thanks.
So he's a Japanese star, Takeshi Tanishiro, but actually because of his Japanese, he has the Chinese name, Jin Seung.
Jin Cheng is Japanese family. So yes, so you can see his body weight, body height, the BMI is normal. And another aspect is his facial proportion. For a male patient, if they want to have a handsome face, usually the facial proportion, upper face, middle face, and lower face is 1:1:1 ratio. And for the upper and lower lip, probably 1:2, 1:2. 2 may be too much. Sometimes people prefer a little bit less than 2 or golden ratio. You can find out what the golden ratio is. For this person, actually, his proportion is good, and also the facial projection. Facial projection means the nose, the chin. Chin is very important for men. And Li Zhili, that's our idol in Taiwan. But she's getting old and had married. She got married with a Japanese star singer. So her body height is also tall, and then body weight is low. BMI just around 17. That's from the record, but maybe higher now. So you can see her facial proportion is also nice. So another thing is that what I'm saying is the facial proportion or the facial structure is related to how good is your sleep. And what type of sleep is good means you probably had heard of the term brainwashing. What is brainwashing? Because during the daytime, our brain is working a lot. So when they are working, there's some garbage or toxins produced during the daytime. So they will temporarily put in the garbage can, just like when we are working, we can produce some garbage and put it into the garbage can. After that, in the night or after your work, the garbage should be thrown away. So the brainwashing is just like the brainwashing is video, yes. So the brainwashing means you know that there's blood vessels, and also there's the lymphatic system. The lymphatic system combined with the blood vessels. During the daytime, because of blood pressure is high, your heartbeat is fast. So the blood flow is so big, and then the vessels are engorged. When the vessels are engorged, because it's a combination of blood vessel and the lymphatic system, so the lymphatic system will be compressed, not able to expand. And only during the nighttime, especially when people are going into deep sleep. Have you heard of what is slow wave sleep? Our sleep during the nighttime, you can tell the patient. The sleep can be divided into REM sleep and non-REM sleep. REM sleep means the rapid eye movement. Why is rapid eye movement? Because the despite the eyelids is closed, but the eye still move around, like you are seeing something. During the REM sleep, people having dreams. So in the dream, you can have running, swimming, or fighting, but actually there's no movement at all. So the signal has been retained in the brain and huddled below the brainstem. So there's some spatial meaning. We will talk about that later. And so during the non-REM and slow wave sleep is the very stable, and then brainwave is very slow. The frequency is about one wave per second. 1 wave per second, just like you're breathing, maybe a little bit faster than you're breathing. But during that time, the blood vessel is more constricted because the blood pressure is low and heart rate decreased. So the lymphatic system has the chance to expand and carry away the garbage. So that has been found out. The full sleep condition is correlated with the dementia. If someone cannot sleep well, such as obstructive sleep apnea or with the insomnia, usually the channel will not be open properly during the night. So eventually the garbage will accumulate in the surrounding the cell, the cell space to accumulate. Then the toxin will stay. So eventually you can find out there's some dementia progress. So if you want to send some patient to sleep center, you have sleep center in this hospital.
Yes.
So usually they will have a control room. In the control room, there's connections to the bedroom, and the patient sleep here, and then they hook up the EEG, EKG, and then the movement, EMG of eyes, and then to the limbs, chest, and abdomen, including the flowmetry from the nasal cannula and oral semester. The oral part actually use the temperature change. When the patient breathes out, it's warmer. When they breathe in, it's colder. So you can have the way that the patient breathing through the mouth. If they have some obstruction or airflow change, so you can find out what's the percentage of the wave change. And also the EEG, you can see from the awake condition, and then to each different stage, 1, 2, and to the slow wave. Here, the slow wave, you can see is 0.5 to 2 hertz per second. So the amplitude is high compared to the others. And in REM sleep, it's a sawtooth wave, similar to stage 2. So this is the different stage. And then you can see the REM in the REM sleep. The character is the EMG, the chin muscle tone is very low. Why this is important? Because when people are using their breathing muscles, there's a lot of accessory breathing muscles. If the muscle tone is low, that means the health, the system of the breathing activity become weak. In that situation, the patient can have more chance to have obstruction. So this is the normal sleep diagram. What is normal sleep diagram? This sleep diagram accumulates the whole night from, you can see here is 11, 12, 1 a.m., 2 a.m. to 5 a.m. 6 hours of reporting. Because most of the insurance payment agree that If you do the recording for 6 hours, they will pay. So no matter the patient going to sleep or not, they just do recording for 6 hours. But if you sleep longer, they stop the recording just around when the recording complete the 6 hours. And then after that one night of recording, they will tell from the EEG whether the patient is in non-REM sleep, like a 1, 2, 3 state, and then REM sleep, and then 1, 2, 3, and then REM sleep. So you can see there's a cycle. One cycle of non-REM and REM sleep is around 90 minutes to 120. So it's 1.5 hour to 2 hours cycle per cycle. So in one night, you can have 4 to 5 cycles, but they cut off at 6 hours, so we can only see about 3. And here is the body position. You can see the tail from the diagram that the patient is in supine position, left position, right position, prone position. So if the patient turn many times or turn more times, means their sleep is less stable. So you can see the patient turn a lot at the beginning of sleep, and then more stable in the later. And also before before the patient wake up, they tend to have longer REM. So you can see here's the first, second, and third REM. And within that one dream, there's a full separation. Usually that kind of separation or stop means you can find certain things correlated with the respiratory events. And here is the SpO2. SpO2 comes from the finger oximeter. The oximeter usually the numbers should be more than 90. Here's 190, 80, 70. If you later on we will see OSA patient. So here records the respiratory events, including the central apnea, obstructive apnea, hypopnea, and then RERA. Okay. So what's the sleep structure related to age? Most of us, we know that when you're getting older, you kind of not able to sleep well. What's the biggest difference? Mainly is the slow wave sleep. Slow wave sleep is the deepest sleep one can get. And during that slow wave sleep, it's related to the growth hormone secretion. When people go into deep sleep, the growth hormone secretes more. And the growth hormone is helpful to human growth, also animal growth. But after the adult age, the growth hormone is helping for cell regeneration. So if someone can have good slow wave sleep, they can keep their appearance youth and beautiful, and then keep for a long time. So have you heard of the story of sleeping beauty? The tree. Sleeping beauty. That's the sleeping beauty. So the good sleep is correlated with the beautiful, the skin beauty. Yes. So the normal breathing usually is a sine wave. Everyone knows the sine wave. But whenever there's a flow limitation, there's some resistance in the upper airway, the flow become different. So the curvature can be dropped suddenly. So the breathing, the flow does not reach to the plateau, just suddenly drop and then coming down. So in that situation, you can see different types of flow limitation represented different structural problems. And if someone snores, you can see during the snoring, there's some. So this is in the night because in supine position, initially there's some normal flow, but gradually with the relaxation of soft tissue, because the soft palate and tongue are muscles. So now we know that in deep sleep or REM sleep, the muscle tend to relax. And after that relax, because in supine position, some part of the structure is supported by bone, but the soft palate and tongue is not. That's why they tend to affected by the gravity and then obstruct in certain period of time. So if there's some, you can see here is the flow limitation. The patient started to making effort. Because anything obstruction in the upper airway will send a message. Because the soft tissue in the upper airway has a lot of receptor. It's quite sensitive. Probably everyone have been done by the COVID test, right? The COVID test, when they insert the tube is the Q-tube is quite irritable. So the signals will send to the brain, and then brain wake up. So you can see after certain unstable sleep, the brain activity become active, and then the patient wake up. So depending on how frequent the sleep is disturbed, that will interfere in nighttime sleep. Nighttime sleep interference will result in daytime function impairment, not able to focus or respond slowly. Probably everyone has some experience. Last night you had quite busy duty, and then during the next day, when you assist the surgery, you feel dizzy or feel sleepy. That's the natural response. Not your fault. Not your fault. Okay. So we know that the definition of OSA was initially reported by Professor Gung. He was my mentor when I was in Stanford University Sleep Center. In 1976, he gave the definition of OSA. And there has been found that 24% and 9% of male and female. That means every 4 males has one OSA. It's quite high incidence, and there's a lot of symptoms. You know, there's could be daytime excessive sleepiness or fatigue or memory loss or even decreased libido and impaired concentration. So without treatment, there's a high risk of cardiovascular or cerebrovascular strokes. So, for example, in this figure, you can see from the EEG, there's a multiple unstable state. And then the chin muscles are making effort, trying to maintain the airway open. And then here, the eyes are moving around. So here's the EKG and the oximeter. You can see initially it's 100, 100, and then there's some drop to 99 or 98. And the breathing wave here, nasal cannula. Nasal cannula is stopped here, totally stopped. And there also the oral thermistor. So here you can see the breathing stop and then the snoring suddenly disappeared. So when someone snoring, maybe better then no snoring. Because when your bed partner does not snore, that means he probably is having or undergoing apnea. So when you see someone come to visit you, complain about having the snoring problem, and the next question for you to ask the patient is, do you hear yourself snoring? Usually the generally the snoring sound will not be heard by the patient. When someone heard himself snoring, or the bed partner, if you hear your bed partner stop breathing, and then certain seconds, maybe up to 30 seconds or even longer, and then the airway pop up, and you hear the sound of like this. Maybe someone had that experience. So in that situation, you can see here is the, and then start regain, come back the breathing. So in that situation, the patient experienced an apnea. So depending on how frequently you hear this, that's the apnea index. So the next part is the hypopnea. Hypopnea means the decrease of the airflow does not coming down to zero, just less than 70%. 70%. So by definition, the apnea means the stop breathing more than 10 seconds. Hypopnea, drop of airflow more than 30% and longer than 10 seconds. Combined with the 3% saturation. If you've got a chance, you can when you go into the OR, you can ask the anesthesia doctor to borrow the oximeter. Put it on your finger and try to stop breathing. Try to let the saturation coming down for 3%. And then you can know what's the feeling of the saturation. It's quite difficult for one person to get the desaturation. So in that OSA condition, actually it's a chronic situation. The desaturation has been adopted by the patient. So because of obstruction, the patient was forced to choose whether you want to desat or you want to have better sleep. You have to make choice. Eventually, the brain will adapt to desaturation by going to sleep. But desaturation has complications because the hypoxia will result in something bad. The worst thing is the reoxygenation. We all know that reperfusion, right? Ischemia and reperfusion. Reperfusion has the reperfusion injury because it produced free radical, similar to hypoxia. So as a craniofacial surgeon, plastic surgeon, we know very well about the cleft surgery. And after the closing up of the lip and nose, the nasal passage becomes smaller. So the airway breathing becomes difficult. And also the hemifacial microsomia patient, because of one side of the mandible hypoplastic, and then the airway also become smaller. Especially for P-robine sequence babies, their mandible is retruding, sometimes combined with the laryngeal mollustia. So you can see the suprasternal depression of this baby, and then the baby, she cannot go into stable sleep. So they tend to have low body weight and very skinny, difficult to increase their body weight and grow. And also the Cruzon syndrome for the patient with mid-face reclusion, the nasal passage is small. Velopharynx collapse. So here you can see the soft palate is touching the posterior pharyngeal wall. What happens is that the patient can only open the mouth and breathe through the oral cavity to the throat. And sometimes even the tongue blocking everything. So the patient needs tracheostomy. In that situation, the patient will need a distraction of the leaf face or even the frontal bone to increase the skeletal framework to relieve the airway obstruction. Why is that? Because here is the you can see the frontal bone, the ethmoid, and the sphenoid bone. Everything in between, there's a synchondrosis. That is the cartilage part. When the patient was born, even with the cranial synostosis patient, they still have some synchondrosis. The cartilage part is the growth center of our skeleton. If the skeleton cannot grow well, then you can expect the airway, nasopharynx is here, and then laryngopharynx is everything is below. And then the framework will squeeze the airway, and the airway is smaller. And then after birth, the growth and development is very crucial because in every age, there's a different shape or form of our skull. So we all know that the baby proportion of cranium and face is more than 1:1. But after adult age, it becomes 1:1 proportion. And if we check the cephalometry norm for every population, this is norm cephalometry for male and female for Taiwanese. So we can create a polygon. The polygon formed by sella to nasia, and then nasia A point to nastia, bonian, and aerial. So by this polygon, we can have this growth pattern for male and female. So in male, from the elementary school, middle school, high school, and adult age, you can see the growth pattern is going forward and downward. So the face basically become more projection and longer. So also the male patient, male people, they have the normal growth pattern. So that's the lateral cephalometry can tell us. So when we take the cephalometry, and then you can see that the normal values of SMA, SMB, and posterior airway space, pharyngeal airway space is more than 11. 11. Very important. The 11 millimeter means the minimum requirement for normal body weight. BMI around 22. Male patient, I think at least 11 AP dimension over the most narrow part of the pharyngeal airway. Pharyngeal airway including from the PNS posterior nasal spine to the epiglottis. That's including the velopharynx and oropharynx. Actually, the nasopharynx is quite okay because everyone's nasopharynx are big. The lateral dimension, the AP dimension is always big. So nasopharynx is not the problem. The problem is over the velo or oropharynx, which is behind the soft palate or tongue. So everyone can tell what's wrong with this patient. He has no chin, very retruded. And in certain perspective, you may say that this patient maxilla is protrusive. But is that true? If we compare to the effect of growth of different facial type, you have the class 3, big class 3 malocclusion with a very large airway, more than 2 centimeters. And then you have the small airway because of retrusion, and then the airway less than even 5 millimeters. You can see that in your clinic. So everything is related to the skeletal growth, because if we superimpose the polygon with our patient, it's still you can find out what's the problem. Usually we superimpose the sella and the nasal because the skull base is quite stable area. Then you can see actually this patient is having maxillary retrusion and severe mandibular retrusion. So both the maxilla and mandible need to be advanced. So that's during the maxillomandibular advancement surgery. Here is the soft palate, the uvula, epiglottis. You can see the endotracheal tube. The anesthesia doctor did not do a good thing because the balloon is over the vocal cord. Not deep enough, probably because of the tube is malpositioned during the surgery. So after we move the maxillomandibular complex forward, the maxilla and mandible forward, you can see the expansion of the airway. Not just the AP dimension, but also the lateral dimension. The soft palate, the tongue base, and then the posterior pharyngeal wall. Everything can be advanced more than 1 centimeter, because usually our endotracheal tube is around 1 centimeter and larger, a little bit larger. Usually they use a little finger to decide which size you choose. So after surgery, the patient can be improved from this left side pre-surgery to left to right side. You can see the improvement in not only the facial profile, but also the occlusion and also the airway. So the patient was cured after the surgery, and we have been following up him for more than 18 years. Still has good outcome. Of course, he is very cooperative, and he controls his body weight and then follow up every year irregularly. So in the other way, OSA can also be found when the patient go for mandibular setback surgery. That has been mentioned long ago, since 1985. That has been mentioned in literature that 2 patients after the mandibular osteotomy setback, there's some snoring and OSA happen after the setback surgery. So gradually there has been a lot of articles mentioning about the mandibular setback, and when you step back more than 9 millimeters, there's 1/3 of patients will develop OSA. And then if you step back less than 5, maybe safer, but doesn't guarantee the safety after the surgery. So what's the common risk for OSA? So we know that before surgery, no matter you want to do some advancement or do some setback of the skeleton, it's important to evaluate the patient before surgery, including the craniofacial structures, airway dimensions, and doing the sacrometry. It's quite important. So there are several factors affecting the OSA, including the soft tissue issues, the skeletal problem, and obesity. So these three parts, we need to do some clinical evaluation from the top to the bottom. The first thing we look at the nose. The nose will count for nasal resistance, airway resistance up to 60%. Just because the nasal valve, the cartilage protruding and blocking the nasal passage, septal deviation, and terminal hypertrophy. And sometimes when the cartilage is soft, there can be collapse during the patient's inhalation. So nasal resistance can be measured with the patient in supine position. That's the better position for correlate to sleep because of hemodynamic change when you put in the patient in supine. And if there's some high nasal resistance, some treatment is necessary, including medical treatment or radio frequency or septaloplasty to improve the nasal passage. So the patient can have the nasal resistance reduced from this to this. The better condition is to have the nasal curve with high nasal flow but low pressure, lower pressure. So in the oral cavity, commonly we can see the long uvula with tapering. Here's the uvula tip tapering. This is a sign of long-term suction power to the uvula. And then the palatal volts tend to be triangular and showing the high and narrow palatal volts. So for patients with high and narrow palatal volts, usually their nasal passage is quite narrow. For those kind of kids, the palatal expansion is necessary. And then we look at the Malampati scale. Malampati scale is very common scale used by anesthesia doctor. Malampati 3 and 4 shows you the narrowing of oral cavity. The intraoral soft tissue is crowded with little space. Both the tongue and soft palate, there's no space to stay there. So do you take SkyTrain here? When you go on SkyTrain, the rush hour, they're so crowded. So what's wrong with the space? The biggest issue is there's no adequate space. So if you expand the space, then everyone can get in. And the other grading is the tonsil. When the tonsil grading is grade 3 and 4, you probably quite familiar with that. Here is the kissing tonsil, and the tonsil cross over 1/4 of the lateral dimension. That's the grade 3 and 4. We need to do the tonsillectomy for the patient to increase the airway size. And other signs, including the mouth breathing, the impact piece, missing teeth, dental crowding, TM joint disorder, and open bite. There are all the signs of craniofacial hypoplastic development. So in class 3 malocclusion, this patient has narrow pharyngeal airway. So you can see the pharyngeal airway was less than 1 centimeter. And the patient also has a high BMI. We sent him for a sleep study, find out that the AHI was 20 and oxygen desaturation down to 80. That's quite significant. So after surgery, what we did mostly is for the maxillary advancement and minimal setback for the mandible. After surgery, you can see the profile actually improved and the AP dimension of the airway increased. AHI coming down to 7.6, but his BMI was still 27, still obese. So the patient need to continue to do the weight reduction or using CPAP in the long term. So another type of class 3, female with narrow pharyngeal airway. You can see the AHI was 1.8. Because less than 5, we think that's normal. But there's one thing I have to mention is that currently we use the same criteria for male and female. That is not fair, right? Because female people actually they deserve lower AHI. Why is that? Because the soft tissue elasticity is better than men. So in normal condition, I would say the airway texture is for female is more like children instead of men. The more like children, children criteria for OSA is 1, AHI 1. So when female patient have 1.5, according to the scoring criteria, people may say that's normal, but in my mind, I think 1.8 still has something not so completely right. So her BMI was also low, but you can see the airway is not quite big. And we did the surgical simulation for her, did some mandibular setback and maxillary advancement and counterclockwise rotation. Because the patient cared a lot about her facial aesthetics, still we need to do some mandibular setback to achieve at least close to the straight profile. So this is the after surgery. You can see the AFI increase just because of the mandibular setback. The airway probably maintain the same AP dimension, but with the maxillary advancement and some mandibular setback, the AHI still increased to up to 6.7. Despite the desaturation down to 93, it's quite, I would say it's probably okay for her, temporary. And the AHI index was not too high because still within the mild range. Mild AHI is 5 to 15. So just cross over the normal borderline. So here at the debonding, the AHI increased to 6.9. So I would say her mild OSA actually become a little bit fixed, not improved after the long-term follow-up. So for her, the facial profile improved from before surgery to after surgery. But you can see what she sacrificed is some certain part of her airway and sleep. So another example is the male patient. He came to our clinic and asked for surgery because of the class 3 malapproval. And initially we noticed that he's quite tall and thin. The airway is slender. So in proportion, basically the airway was not large enough. So during surgery, we did carry out the surgery quite carefully. Initially, the surgical planning was maxillary clockwise rotation, mandibular setback for 7 millimeters. That's the initial planning. And during the surgery, we find out that airway decreased too much. So eventually, we moved the complex forward a little bit, just let the mandibular setback at 3 millimeters, just 3 millimeters. But you can see the profile. Maybe yes, it's a little bit, still a little bit pronounced, at the mandible. So at post-op 3 months, we can see the Malapati score was 1. And 4 months, he started to complain about his face because after the swelling subside, the facial convexity increased because of the cheek become more subside of the swelling. So he started to complain about black face. And in 6 months, he asked for revision of surgery. He wants to set back more. He has specific facial convexity requirement. So I would tell you actually he's a medical doctor. He's a radiologist. He sees thousands of X-ray, and he asks for his own facial convexity. So the surgical planning, we did the secondary planning. The secondary planning was to achieve the original simulation. That is setback more, 4 millimeter more, 4 millimeter more. And then rotation 1 millimeter for maxilla. However, after the second surgery, 6 months later, after debunk, the Malapati score become 2. So you can see the oral cavity more narrow, and then 1 year later, we follow up, the AHI was 6.5. But apnea index was 0. The oxygen desaturation down to 83. That's the lowest part, but generally probably more than 90. After he saw his facial profile improvement and AHI increase, so he said, "I'm satisfied with my facial profile, but I'm feeling that kind of sorry about the AHI increasement. So what can I say? I told you." So that's the final position of MNC, similar to first surgical planning. So this is the story of this patient. We learned that the sleep and breathing problem can happen with a significant setback of jaws. A conflict may happen between the facial aesthetics and function of the operator. That's what we should keep in mind when we do the aesthetic surgery for our patients. So in summary, the airway is very crucial to part of pre-surgical evaluation for orthodontic surgery, because our perception of facial aesthetics tend to push back the face to the age of about 18 or 16 years old. That's the most attractive face for female, maybe for male. So currently in the medical market, you can see a lot of surgeons. They are doing a lot of setback, creating a smaller face, delicate face, and if they do it without consideration of airway, that's quite risky. So for patients with structurally narrow, they should send for polysomnography, sleep study. And when you see questionable airway or sleep and breathing problems, we should consider less setback and more maxillary advancement. So in that type of design, we still can create a quite attractive AMB. But there's some worry if the patient's nose projection is insufficient. They may not be able to accept that. So the pre-surgical consultation for more stimulation, even telling the patient that you probably need nasal augmentation after the orthodontic surgery. That's what we can do for them. So thank you, and then welcome to Chang Forum this year.
Thank you very much, Professor Lee, for a very detailed lecture about the airway considerations. We have to say that actually this topic is quite new for us because usually in our hospital right now, we do the OGS to treat the patients with craniofacial deformity and some of the aesthetic points. But for sleep study or the sleep patient, we still have not so many patients with the OGS. So this is kind of new